Welcome, participants, to today's webinar. This is Dr. Marnie Peterson. I'm the Outreach Coordinator for the Antimicrobial Stewardship Project, which was launched last year by the Center for Infectious Disease Research and Policy at the University of Minnesota. We have an exciting webinar for you today that's titled Emerging Multidrug Resistant Candida auris and Considerations for Antimicrobial Stewardship. This webinar will be presented today by a Centers for Infectious Disease Control and Prevention expert, Dr. Tom Chiller. Before we begin, just a little bit of background for those of you that aren't familiar with Dr. Chiller. He is the chief of the Mycotic Diseases branch at the CDC, where he provides leadership for domestic and global activities in fungal diseases. Dr. Chiller received his bachelor's degree from Dartmouth College and his medical and public health degrees from Tulane University. He completed a residency in internal medicine at the University of Texas Southwestern and a fellowship in infectious diseases and mycotics at Stanford University. He then joined the CDC in 2001 to train in infectious disease epidemiology as an epidemic intelligence service EIS officer. I would like to thank all of our participants that are joining us today and want you to know that at any time during this webinar, you can submit questions or comments in writing to Dr. Chiller via the WebEx chat box that's located at the bottom right corner of your screen. Type in your question, and when you do so, make sure you send your questions to all panelists. We will have time at the end of the webinar to answer your questions and for further discussion. Just be aware that all of your lines will be muted during our webinar, and also that this webinar will be recorded and will be available after today on our YouTube channel. So with that, I'd like to thank Dr. Chiller for joining us today, and we look forward to your presentation on this important topic.
Well, thank you very much, and it's a great pleasure to be here talking to everybody. I am thrilled to talk a little about Candida and its relationship in a bigger sense to antimicrobial stewardship. I think oftentimes we sort of leave out the antifungal stewardship when we think about antibiotic stewardship, which is generally focused on bacteria, which is obviously incredibly important. But I'm hoping to show you a little bit by using this example of this emerging multi-drug resistant yeast about how stewardship is going to be important moving forward in the future, and obviously its importance as it relates to resistance. My first slide, though, is just to mention thank you for joining me during this first ever Fungal Disease Awareness Week. This is the first annual, and hopefully we'll begin an annual event where we will try to focus our attention on getting people to think fungus. So again, thanks for joining me in this Fungal Disease Awareness Week. I think when we think fungal infections, a lot of times this is the first thing that comes to mind. The nasty and cosmetically challenging fungal nail and skin disease. I think when we think threats to the infectious disease world, we often think of the CRE bacteria that are causing a very difficult to treat bacterial infections. And we also think of the new kid multi-drug resistant Acinetobacter as another major problem in hospitals. MRSA, which has now become widespread, we continue to remain concerned about as it moves now into communities. And then finally, C. diff, which used to be sort of a rare pathogen, now is much more common, and we're using very interesting methods to try to combat C. diff with all the way to stool transplants. But what I want to talk to you about is fungus, and because there is a fungus among us that is very concerning to all of us in the healthcare world. Just a couple steps back about fungi and specifically Candidemia. As you all know, fungal infections can be very serious. Candidemia, which is the presence of Candida in blood, has recently been shown in many hospitals to be the most common, if not one of the most common, healthcare-associated bloodstream infections in the United States. And so it continues to remain an increasing challenge to those of us working in hospitals and healthcare settings. You can see the incidence is somewhere around 5 to 15 per 100,000 population based on the limited amount of data we have. And mortality rates have unfortunately stayed relatively consistent over the decades. Despite better antifungals, we're still dealing with a 30 to 50% all-cause mortality. And, we think that Candida probably has an attributable mortality of somewhere around 15 to 30%. When we think of the typical risk factors for Candidemia, which sometimes we like to call the other C. diff, we think of broad spectrum antibiotic use. This is always the number one risk factors that comes up, and that immediately brings us into the topic of stewardship. Just like with C. diff, where if you use antibiotics, you kill off a lot of the good bacteria, and C. diff remains. It's the same thing with Candida, as Candida is in our guts and is a commensal organism. But if we use broad spectrum antibiotics, we eliminate all the good bacteria and obviously hopefully the bad ones if that's what we're treating. But what remains is Candida. And in patients that are immunocompromised or in the hospital for a prolonged period of time, like in the ICUs, or have had abdominal surgery where they're exposing those commensal flora potentially to the outside or to other parts of the body, and then central lines, which can cause a portal of entry. All of these conditions we know are risk factors for Candidemia, but none so much as the use of broad spectrum antibiotics. So where is Candida coming from? I was just saying that the conventional wisdom is that the sources of most of these infections come from our own gut flora. So essentially we develop an auto-infection. Transmission in the hospital is actually very rare. Outbreaks are reported, and we do see some small outbreaks time to time, but this is the exception, not the rule. And so most Candidemias that are occurring are the patient brings their own Candida in with them, and because of these risk factors we just talked about, they're able to translocate out into the bloodstream and cause bloodstream infections and sepsis. If we look at the Candida species distribution in one of our surveillance systems in the Emerging Infectious Program, here's a smattering of about 7,000 isolates over the time we've been collecting them. And you can see in the blue Candida albicans, which probably many of you are familiar or have heard of the name Candida albicans. This used to be the king and was always causing at least 50% to 70% of all infections. You can see that the blue now represents about a third, with the orange representing close to that same amount, the third, the orange being Candida glabrata, and the third most common species, Parapsilosis, between those three species representing close to 80% of all Candidemias. In some hospitals now, Candida glabrata is more than 50% of the Candidemia, and Candida glabrata creates specific problems because it also tends to be the most resistant of all the Candida species that we're describing in this particular surveillance system. So why do we care about this new species, this relatively obscure Candida species that's called Candida auris? Well, let me give you a little background on its discovery and emergence. In 2009, this particular Candida was described for the first time in the patient, in a patient's ear that was in Japan, and therefore the name auris. Auris is the Latin word for ear. We subsequently saw a pretty rapid emergence since 2009 with reports in the literature from South Korea, India, South Africa, Kenya. We also spoke with colleagues in Pakistan, Venezuela, Israel, and the United Kingdom. And you can see that in a relatively short period of time, it came onto the scene in about 4 continents and in multiple countries. The other thing that we learned about this as we were sort of monitoring its reports is that it was very resistant and often multi-drug resistant. Most, upwards of 90% of these isolates were resistant to azoles. 30 to 40% resistance to were resistant to polyenes, which are in this setting amphotericin B. So, and you're all probably familiar with amphoterrible, as we like to refer to it because of the side effects. And then finally, a certain percent were also resistant to echinocandids, and a few of these isolates were actually resistant to all 3 classes. And these are the 3 major classes of antifungal therapy for invasive disease, making those few isolates that we heard about and that we characterized resistant to really all known treatment modalities. And that obviously concerned us quite dramatically. Many, I think upwards of 40 to 50% were resistant to 2 of these drugs, so there still was an available option. But knowing that there could be triple resistance developing, this was obviously quite concerning. I think when we first started seeing this emergence in the literature and then talking with colleagues, I think there was a healthy amount of skepticism that was this true emergence? Was C. auris actually with us the entire time? Maybe because we continue to develop newer diagnostic methods, that this would be responsible for its so-called emergence because things like MALDI-TOF and DNA sequencing were allowing us to characterize a lot different species. And most systems were actually misidentifying this particular Candida as Candida hemolonii or some other species. We went back and looked, obviously, to try to understand this. And when we look back at our surveillance system of somewhere around 7,000 isolates over the last decade, there was no C. auris. And again, going back and retesting isolates if needed to be. We also worked with the Sentry and Artemis programs. These are private collections from 4 continents, over 30,000 Candida isolates, and they had seen no Candida auris before 2009. We had heard of a report of an isolate that had been recorded in South Korea back in 1996, but that's the only thing we could find. And again, in talking to colleagues and other professionals looking at Candida around the world. So it did really appear that it was emerging now or emerging within the last decade. So how was it emerging was obviously the first question we asked. Is this a global spread of a single epidemic strain, maybe through some food or medical product, or were these mini introductions from the environment or some other source happening somewhat simultaneously? So we turned to a technique that we now use quite readily in public health, but it's somewhat new in the fungal world, and that is whole genome sequencing. So taking the entire genome, sequencing every base pair to understand and look at that and compare that with each other. Interestingly enough, we found quite remarkable but also puzzling results. Here are the first 47 isolates from 4 of these regions that we showed on the initial map. You can see here that using whole genome sequencing, you compare single nucleotide polymorphisms. They're called SNPs, and essentially that's one base pair difference. And so you get a very, very precise and detailed way to look across genomic sequences, and you can see that we sort of characterized these 47 isolates into 4 distinct clades. And these clades were incredibly different. We're talking 40 to 400,000 SNPs difference. And that's a tremendous difference. Just to give you an idea of the contrast, in the regions themselves, so in South America, in East Asia, South Asia, we're talking less than 70 SNPs. So incredibly clonal within a region, but incredibly distinct without. Certainly suggesting that these weren't related, in time, in the amount of time that we were seeing emergence, and again suggesting that this was a simultaneous emergence in multiple continents. And then we got our attention really peaked when we spoke to colleagues in the United Kingdom. They had a Candida auris outbreak in one of their hospitals. 9 of these were bloodstream infections. More than 40 people were colonized. And they described to us what appeared to be clear patient-to-patient transmission. And remember, I had said that patient-to-patient transmission is not something that we commonly see with Candida and that we commonly worry about. But in this case, they were seeing clear patient-to-patient transmission. And they had an incredibly challenging time controlling this outbreak. They used contact precautions. They were screening people to see if they were actually colonized with Candida auris. They were using chlorhexidine bathing. They were cleaning the rooms with bleach 3 times a day and then doing a terminal cleaning of these rooms with even a higher concentration of bleach. They eventually had to close the ICU for a period of time. And to me, as a mycologist, someone who's been doing fungal infectious disease work for a long time, to close an intensive care unit based on a Candida is just unheard of. And so this really got our attention and really got us thinking that this particular yeast was not acting like a typical yeast at all. So that really got us to be as proactive as we could here in the United States, and we put out a clinical alert to healthcare facilities in June of last year. What we were trying to sort of get up on front of is the example that I think I'm going to use here with CRE. I mean, if you look back at 2001, this is the map of CRE in the United States when it first got reported in one state. And then fast forward 15 years later, and here's the map. And I imagine now all the states have been isolating this. And so we were looking at Candida auris with this in the back of our minds, thinking, this is what we want to try to avoid. Let's get out as much on front with this organism as we can and see if we can't contain, control, and even try to eliminate its potential spread. So after the alert, we found out about a number of cases. Hospitals, states, counties began reporting to us and helping us confirm that indeed there were some cases. I think this is a slightly older epidemiological curve, but on our website we update this regularly, and I think now our current case count is a little over 100. You can see that many cases are in New York and New Jersey, and if you look on our website, we also have this map that sort of points out where cases have occurred, and you can see there's been quite a few in New York and New Jersey where we believe it's been introduced some time ago and has had some time to transmit locally, and I'll show you that here in a moment. So just getting some of the initial epidemiology characteristics of our U.S. cases, 75% of these isolates are in blood, so they're Candidemia. The median age is 70. We have had one neonatal case to date. Multiple underlying medical conditions and indwelling devices, tracheostomy tubes, CVCs, gastrostomy tubes, and really extensive healthcare exposures amongst these individuals. In acute care hospitals, LTACs, SNFs, so they've been very, what I would say, medically experienced patients, so very high risk for nosocomial and hospital sort of acquired issues. The bugs, the Candida auris that we looked at initially have about an 80% resistance to fluconazole, so pretty typically of what we saw in our initial global study, 40% resistance to amphotericin B, and thankfully a very minimal number of these are resistant to echinocandins, somewhere around 3% now. Again, most of these have individual resistances, so this is not saying that these organisms are resistant to all three. There are some with 2 drug resistances, and thankfully in the U.S. so far, we have not encountered the triple resistance, which would render us, very challenged in trying to treat one of these isolates. And the mortality all cause is about 30%. It's hard to really understand a true attributable mortality in this case because these patients are quite sick and are very medically experienced. We have had some conversations with colleagues globally, and they, in looking at some of their patients, do feel that this organism is indeed causing mortality itself, but we're still trying to understand how much mortality is caused by C. auris versus people who are dying with C. auris. Let me just illustrate a little bit about, again, the cases epidemiologically and where they're coming from. We've had 4 cases that were pretty clearly documented to be associated with recent travel. The countries involved were India, Pakistan, South Africa, Venezuela. If you recall from the original emergence map, all of these were places where we knew Candida auris was emerging. The cases here, though, involved urine and wound cultures, which are generally not something where Candida is speciated. And so that took a little extra sleuthing and for these particular hospitals and healthcare facilities to actually realize what they were dealing with was a Candida auris. These occurred in 4 different states that you can see listed on the slide. As we've been collecting and working with states and hospitals on their cases, we also are continuing to perform whole genome sequencing. And one of the reasons we're doing this is to try to understand where they're coming from. As you just saw, we know some were most likely associated with travel. And we also wondered if, as has happened in some of these other countries where they have their own strains or their own clades, is that what was also happening in the United States? And I think this slide will illustrate that the U.S. cases and all the isolates are related to those from actually multiple parts of the world, but they are closely related within each state. And you can see here the South Asian clade. We've had a number of isolates introduced into groups, New York, New Jersey, Oklahoma, Connecticut, Maryland. There's also been an introduction of an East Asia type strain into New York, Illinois, Massachusetts, Florida with South American strains, and then even in Indiana, introduction with a South African strain. And so I think what we are seeing here in the United States is pretty recent emergence. Around mid-2015 we had a case from 2013. It's a little bit unclear, but from mid-2015 on, we certainly have had multiple introductions of C. auris, and then followed by what appears to be some local transmission because these strains remain so clonal in some of these areas where there has been more cases reported. So then we went back to this idea of transmission, since we had heard so much from our colleagues in the UK about how challenging this thing was to control and that they were convinced that this was being transmitted person to person. Why were they convinced of that? Well, they were convinced because they would have a patient in a room, they would clean the room, they would put a new patient back in the room that they knew was not colonized, and that patient would become colonized with Candida auris. And so this was obviously not the typical way in which they were thinking that Candida infections and Candida colonization happens. Again, we often think it's coming in from our own GI tract. So one of the things we noticed right away is in working with several groups is that Candida auris really likes the skin, and it colonizes it quite well as some other body sites, especially the growing and axilla regions, but also, as you can see, the ears, nares, mouth. One of the things that we found in the lab that was really interesting about this particular Candida is it likes to grow in high salt concentration, so like twice the concentration of the ocean, and also slightly higher temperatures than body temperature. So body temperature being around 37 degrees Celsius, this organism really likes to grow around 42. And you can imagine then that the axilla, areas where you sweat and that are slightly warmer, could be ideal sites to find this organism, and indeed that was and is the case. It also, though, likes to colonize and contaminate the environment, and has been found for weeks to months on surfaces, in healthcare associated settings. So if you look at this picture of the room, on the bed, on the windowsill, even on the floor, on the chair, on handrails, it tends to easily and readily contaminate an environment and stay there. When we looked with some colleagues at some of the people who were cases, you can see here 3 cases where we actually looked at some close contacts. So these were either people that had been in the same room or in the same hallway. We were able to document, at least in this preliminary study, that there were close contacts that from 2 of these cases that were indeed colonized with the same strain of Candida auris. Once again suggesting, as they had in the United Kingdom, that this was an organism that could be transmitted within healthcare settings, either via surfaces or via person-to-person transmission, but it was being transmitted in that way. We also looked ourselves and did some experiments to see how long it could persist on the skin. I think our longest persistence is up to 9 months now. So it generally appears to be pretty happy on skin. In the lab, we can easily get it to persist on different plastic surfaces for greater than a month. And one of the things we also learned early on is that the quaternary ammonium compounds, which are very, very highly used in healthcare settings, were inadequate for disinfection of this pathogen. So this is really a paradigm shift for what one would think of as invasive candidal infections. First of all, antifungal resistance here is the norm. Almost all of these bugs are resistant to at least one drug. And the other thing to note about that is that all the data suggests that they are also very happy to be resistant, or a term we like to use, fit. They are very fit when they are resistant. They do not want to revert back to being not resistant. And so that is obviously something in a pathogen that we don't like to see. The other thing is that it just thrives on the skin, and as I mentioned, especially in the underarm, and on the axilla and inguinal areas, it can stay there for months. It contaminates patient rooms, and again, we've seen patients leave rooms, done cleanings, and then gone back and found it, and we think also had been transmitted to another patient that occupied that same room, which was seen multiple times in the case of the hospital in the United Kingdom, and therefore is spreading and can spread in these healthcare settings, which again it's acting like a bacteria. It's acting like those bacteria, CRE, MRSA, and Acinetobacter that I talked about at the beginning of this talk. So it really is a paradigm shift for all of us to be realizing we have to treat Candida auris infections like we would treat readily transmittable, highly resistant bacteria. So that brings us to the controlling the spread. And obviously controlling the spread then means we need to know it's there. We need to treat it appropriately with taking into account susceptibility profiles, stewardship, and we need to follow our typical and usual infection control where we're washing hands, alcohol-based gels, etc. So hand hygiene, and obviously contact precautions. One of the things with identify is the challenges with identification. As I mentioned briefly earlier, this species is readily identified with a MALDI-TOF or using DNA sequencing, but that's not always available in clinical labs and micro labs, and and certainly globally, that's not always available. So often it gets misidentified in the current biochemical methods of identifying and speciating as different types of fungi or as nothing. Candida hemolonii is the most common misidentified organism, and we've seen clusters of Candida hemolonii that in fact were all Candida auris sent to us. But you can see here there are some others, and our website that I'll highlight here in a moment really goes into detail to help microlabs and clinicians realize where they may have some faulty identification. The other thing about identifying is that about 30% of the clinical cases we've seen so far in the U.S. have been from non-bloodstream isolates, so urine, bile, wounds, etc. So these non-sterile sites, or sort of pseudo-sterile sites, so to speak. Generally, isolates from those sites, if they're in a microlab, they get tested and they may say Candida, but these do often not get worked up to any particular species level. And even though I would say most of the time there's not any treatment warranted for these particular sites, if we're going to find if we're going to find Candida auris there, we're going to need to act, right? Because it's different than the typical Candida, and we need to put more aggressive infection control measures in place. There's also been obviously challenges in detecting these colonized individuals because we're not speciating, but also just going out and doing swabbing. This is a technique that is generally not used for Candida. We're not swabbing people for Candida on any routine basis, so we've been working hard to try to develop some protocols. And what we've done so far is to do swabs that are really focused on the axilla and growing, so one swab that would go to both sides of the inguinal, the growing area, and both axillas, and then we can look for Candida auris and see if there is, if it has colonized a particular individual. Clearly, we need to know if folks are colonized and have it, because that, again, is going to prompt us to do much more aggressive infection control. I also want to point out something else we're doing that is relatively new over the last couple of years with public health and state partners, and that is establishing an ARLN laboratory network, which stands for the Antimicrobial Resistance Laboratory Network. These are the labs here on the map. And Candida is part of the core testing now for all 7 of these regional labs, and they are going to be working on, if they aren't already, Candida auris. Clearly, these labs are meant to be there to help us understand emergence of resistant pathogens, where they're coming from, and learn better ways to identify them quickly, etc. So we're excited to participate with states with this network, and hopefully you'll see the benefits of getting this network up and established very soon. Just turning to treatment and talking about, again, this as it relates to stewardship. One of the things that IDSA has most recently recommended in their newest Candidemia guidelines is the use of susceptibility testing to help you guide treatment. And that is because we are seeing an increasing amount of Candida glabrata that are echinocandin resistant. We also see a number of them that are fluconazole resistant. And so even though echinocandins are first-line treatment, we are seeing the emergence of echinocandin resistance in our Candida populations. And so it is going to be important for you to think about and get susceptibility testing when you do see a Candida bloodstream isolate. Certainly for Candida auris, thankfully in this country, echinocandin resistance is rare. It's probably more rare than it is for glabrata across the nation. And of course, the organism itself is much rarer. But we know in other settings, echinocandin resistance can be quite high as 30 to 40%. And we're clearly worried about that. that phenomena. One of the things that makes us worried is that some of these echinocandin resistant isolates have become resistant while on echinocandin therapy. We've documented at least one here in the U.S., but I think there are others that we're hearing about, and that's very concerning because, again, these organisms generally do not acquire resistance while on treatment. That is more typical of a bacteria. So once again, this Candida auris acting more like a bacteria than a yeast in that case, but certainly causing us to worry and causing us to, again, rethink and make sure we're talking about stewardship, because once again, using these drugs appropriately with appropriate monitoring and susceptibility testing is going to be key in trying to cut down on the development of this resistance. So bringing it all to this concept of antibacterial, and I want to add antifungal stewardship or antimicrobial stewardship, and really controlling the spread of Candida, we need to think about this almost in two ways. One is we have to focus on antibacterial stewardship because it's just like C. diff. If you misuse, overuse, inappropriately use antibacterials, you're wiping out all the good bacteria. Obviously, some of the bad, but that would be a focused therapy, and you're going to leave your body's ability for the Candida just to thrive without any competition from bacteria, and you will see Candidemias develop. You will see Candida overgrowth, and that is really the most important risk factor for Candidemia, broad spectrum antibacterial use. Antifungal then is the second step. Once you've established that there is a Candida infection, or if you suspect a Candida infection, we need to be thinking about stewarding these important drugs. We only really have 3 classes of them right now that we use for invasive infections. Oftentimes, the antimicrobial stewardship programs don't really include antifungal stewardship. So they're really limited in what's out there. It's not a common part. So we need to be thinking about it, especially now, thinking about 50% of the Candida auris cases that we know about approximately have been on antifungals. So they were cultured while they were taking antifungal. And if you think about it, it makes some sense because Candida auris is broadly resistant to fluconazole. Most of these people who were on antifungals were on fluconazole. It's certainly going to select for Candida auris in that case. There's also a lot of empiric use out there of antifungals, and I think we really need to combine this with better diagnostics. There are, some important potential culture-independent diagnostic tests coming out that don't, and I think we need to think of this slightly differently. We don't, a positive test is obviously really important, but a negative test with a very high negative predictive value is also extremely important, because if we can rule out that it is not Candida, then we can get rid of any antifungals that we're empirically using in our sick patients and focus on other reasons why that patient is sick or septic. So, in relation to Candida auris, unlike, again, other Candida, infection control is another really important key for stopping its transmission. Hand hygiene is incredibly important, contact precautions, and of course, disinfection. So when we look at some of the recommended infection control practices, these are things that are very common in hospitals, and we just want to reinforce it. They're just not commonly associated with a fungus. So here we're dealing with standard and contact precautions, placing patients in a single room, the importance of hand hygiene, daily and terminal cleaning. But we've realized, because these quaternary are not working, that we're currently recommending disinfectants that carry a Clostridium difficile claim. So that's the highest claim by EPA, a sporicidal claim. And then finally, doing contact tracing for those cases you identify is also going to be important in trying to contain and control. Just a couple words before I finish on the global situation. Candida auris is now common in some international hospitals and settings. Up to 40% of the candidemias in one Indian hospital and one Kenyan hospital that we've spoken to, but I imagine it's in many more. So candidemia, so bloodstream infection caused by Candida, are Candida auris. That's what we're concerned about. 10% of Candidas in some private hospitals in South Africa have been reported to us. And we know that it's been in Venezuela for a while, and unfortunately, there's very limited diagnostic capacity, but we do think there are hundreds, if not thousands, of cases in Venezuela, and we're certainly concerned about how much of that is making up their Candida and Candidemias. Cases are now in other parts of the Americas, Colombia and Panama. UK continues to have introductions, and there was just a report out yesterday in the UK press that it is in upwards of 55 hospitals now across the country. We actually haven't gotten any further isolates from where it was named in Japan, and also relatively few in South Korea. And there's obviously major unknowns out there in most of Africa and other parts of Latin America. So we're trying to work to understand this better. So ultimately, we need to do some further work on this, as you can tell. It's an emerging area. We need better diagnostics, and maybe diagnostics that don't always depend on a culture, but allow us to have a negative predictive value that allows us to stop an antifungal. And so, again, tying diagnostics into stewardship is critically important when we work with both bacteria and fungi. Expand our understanding of the epi, and especially risk factors for both invasive infection and colonization. We need to characterize resistance and resistance development and virulence factors. As I mentioned, to me, it's a bit scary that this thing is developing resistance while on therapy. That is not necessarily what we think of when we're dealing with Candida. And again, this particular pathogen seems to be very happy when it's resistant. We also want to obviously look at some of the newer antifungal agents, because we do have this potential for a pan-resistant Candida auris that's out there. It is somewhat exciting because there are some new drugs in the pipeline that have different mechanisms of action. We haven't had a new drug on the scene in the fungal infectious disease world in 15 years or more. So this is going to be important to get those drugs out, and I'm hopeful that there will be good activity and vigorous activity to find new antifungal agents. We need to assess some decolonization strategies. We know how we are struggling and challenged with this in the bacterial space, but so you can imagine in the fungal space, it's going to be also just as challenging, but decolonization so that we can clear patients is going to be important, and we're working to try to understand that. Strengthening infection control and evaluating the effectiveness of various interventions that we do in the infection control space is something that's ongoing with a lot of different pathogens, but now we need to think about adding Candida in there. And then finally, if we can work some more on understanding the environmental niches. So in summary, Candida auris causes invasive infections with high mortality, challenging to identify, can be multi-drug resistant, is transmitted in healthcare settings. Surveillance and infection control are really needed to help understand and control its spread. We need to screen close contacts. We need good antibacterial and anti-stewardship practices. You can see a lot of our information about this organism on our website, which is on the bottom of this slide, but please go there and look. We are updating this constantly. And finally, again, thanks for joining me during Fungal Disease Awareness Week. Get involved, obviously, surveillance, raising awareness like this, and talk to your colleagues and friends. And then if there's a case detected, please report to your local health authorities, and because we need to work with them on containment, control, and hopefully elimination. Thank you.
Thank you, Dr. Chiller, for your very interesting overview of this new emerging pathogen. Very important. I just want to remind participants that are with us to please submit your questions via the chat box now, because we've got a good 15 minutes here to engage with Dr. Chiller and get his perspective on this. We've had a couple of questions submitted already, so I'm just going to go right into those, and then we can carry on from there. One of the questions that one of our participants wanted to know is, how common is it to identify a new fungus or a new species of Candida? And was Candida auris particularly interesting to you because of its resistance profile? Because it was one of the more recent ones identified, both? Maybe you could shed some light on that, Dr. Chiller.
Yeah, great question. It is, so taking a step back and thinking about fungi in general. Fungi occupy actually an entire kingdom of organisms. They're the most common organisms on this planet, and as you all know, because you probably eat them or drink them, or there's all different types. So of the more than, I think, 1.5 million different types of fungi, there's only a few hundred that we know of that are pathogens to date. But with more and more immunocompromised patients, in other words, people with transplants and on immunocompromising drugs that are around there, we absolutely do see new emerging so-called fungal pathogens every year. I think the difference is that in Candida, which is well known, and again, there are several hundred species of Candida, most of which are not pathogenic. This one caught our eye particularly because, number one, it was multi-drug resistant. And again, it was the first Candida that had resistant to all three known antifungal invasive drugs that we need. So that was really important to us. And number two, as we learned more about it, as I've mentioned, it wasn't acting like any of the other Candida species, or at least most of them. There are some that are, we think, that are transmitted occasionally in the hospital settings. There are some that are living on skin, but none as happy and as vigorous as Candida auris. And again, having us change this paradigm that we're reacting to a Candida infection like we're reacting to a multi-drug resistant transmissible bacteria is something very different for us in the healthcare community.
Thank you for that answer. A second question, you mentioned in your presentation about the importance of diagnostics, and particularly a negative predictive test, and how we can combine that with our stewardship practices. A question from one of our participants, they're wanting to know if there are any current negative predictive identification tests that you would recommend to try to quickly rule out that the cultures are negative for Candida. Is there a test that you recommend?
Yeah, so there are a number of, well, I shouldn't say there's a number. There's a couple of different tests that are being tested now that are potentially going to be very good in this space. There is really nothing out there yet for Candida auris per se, but there are a couple different tests, so these culture-independent diagnostic tests to look at for Candida. And not mentioning any specifics by name, I think it is worth looking into that a bit and seeing what is available and what is out there. I think there are some exciting possibilities as we move forward in this space. Candida right now, at best, maybe has that we can isolate it 70% of the time in blood, but I think more reasonably it's probably about half the time that we find it. So it is going to be important to have other diagnostic modalities to try to, again, rule it in, or even better, rule it out, so we can stop empiric antifungal treatment.
So a follow-on question to that relates to colonization. And I don't know, as you develop your protocols, how much we're going to be testing for colonization as people enter healthcare facilities. But the question is, once it's identified that a patient is colonized with C. auris, what's the recommended approach then for treatment and monitoring? And maybe there's even isolation strategies too.
Yeah, that's a fantastic question, and it is certainly a challenging point and something that we are looking at routinely now and trying to develop our strategy to work with hospitals and infection control practitioners. I think the basics are, if you were to find someone colonized or a case, you would certainly want to put that patient in an individual room and put them on contact, precautions. You would also then want to understand how extensive the contamination or colonization is in that particular healthcare facility. We've been doing that mainly by doing sort of what we call point prevalence surveys. So we will test patients and see if they are colonized, and if so, similar approaches. A colonized patient, we put them in a single room, or you might cohort them, although we prefer not to do that. And then we do standard contact precautions. I think the more challenging part of that question is, okay, so how do we then deal with these patients? And there have been a number of different things tried. I know in the United Kingdom, they were trying all kinds of different ways to use chlorhexidine and chlorhexidine baths. You know, I know that the use of chlorhexidine in the bacterial world is also quite controversial. There are pros and cons out there. We haven't seen necessarily some sort of great efficacy using chlorhexidine with Candida auris, but I really think that remains to be seen. So what we're trying to do is to gather as much information we can from those who are dealing with patients, and seeing if there are going to be decolonization protocols that can be used to help make these patients or colonized persons basically eliminate C. auris from their skin, so that we can then house them again without contact precautions. I think for those people who are actually sick or have invasive disease, obviously treatment is warranted in those with an antifungal and again the same sort of contact precautions that you would with a colonized patient. I think one thing we do know is that it's really important to do cleaning of the room and to do terminal cleaning with these high C. diff disinfectants, so the sporicidal disinfectants. That is going to be really important, and that we do know works.
Another question. From your presentation, you discussed that C. auris has been associated with not only bloodstream infections, but isolating it from urine, from wounds. A question about other deep-seated infections. Have any of those been identified, maybe in the organs of transplant patients or other sites?
Yes, there absolutely have been other sites of deep-seated candidiasis identified. So it does certainly seem to be acting in some ways like sort of the typical invasive Candida infections with an array of different deep-seated abdominal issues, etc. We don't have a lot of information on the clinical specifics of a lot of the cases outside of the U.S. Again, the cases in the U.S. are very medically experienced. You can see most of them were blood. But we do know from talking to colleagues in countries where they are really dealing with some pretty dramatic rates that the patients there tend to be and are looking more like the typical Candida patient, where there are risk factors like diabetes and immunocompromising states, etc. And they are getting sort of a more typical picture of invasive Candida. I will say again that in talking to some of those colleagues, they do think that some of these patients, up to maybe half of them that are identified with Candida auris invasive disease, are actually dying of the Candida auris. That is yet to be verified by at least our group here, but it certainly raises concerns. We know that Candida species in general can be attributable more to a high mortality depending on the patient at risk.
A question from participants pertains to infection control practices, and they're wondering about if there's a high propensity for skin colonization. Do isolation precautions, are you also going to address visitors to these particular patients? So I know that you've identified in your webinar talking a little bit about other case contacts. So are there also isolation precautions with the visitors?
Yeah, I think just like any hospital would be dealing with a patient's visitors that was under contact precautions, it's going to be very similar. You're going to have to gown and glove if you're in that patient's room as a visitor. And so I think there are very adequate and standard sort of protocols for dealing with some of these other organisms that we also know are transmitted readily in the healthcare environment. So it's going to be very similar. And I think that, again, the challenge is that when you say, oh, you're on contact precautions for Candida, the typical reaction from probably most of us in the healthcare world would be, what? So I think that's what's taking a little time and effort by all of us to really educate folks that, no, this is a different type of Candida. This is more like an Acidonitobacter.
What's concerning, in looking at this back to a global perspective, is if you take the UK, for example, that it's continuing to be introduced, as you mentioned. I assume it's also continuing to be transmitted between patients. So despite some of their infection control protocols, this is continuing to increase. So what are your thoughts on how we're going to be able to prevent this from continuing to spread within the United States? It seems like it's very concerning.
I think that's our number one priority, is thinking through that. I think you've adequately pointed out that we know that there are different levels of sort of infection control and containment strategies depending on the countries and maybe the level of which it is manifesting within the healthcare community. I think specifically speaking to the United States, thankfully it's still exceedingly rare. It is in a very healthcare exposed population. We are taking a response level that is to react to any single case, to understand where it is in the environment around that case, and to do everything we can to decontaminate, disinfect, and if possible, eliminate from the environment. And obviously struggling a bit still with how we're going to disinfect or decolonize persons, and that's probably one of the bigger challenges that we're working on and trying to understand the best way to do it. I think we have to, like with any of these things, we're going to have to remain vigilant. I think that we are going to have to start thinking about who do we screen, looking for this coming into a healthcare facility. I think right now we are working on developing some guidance for healthcare facilities. One could imagine that if you knew that there was a patient coming in that was medically experienced from a country where we know this is quite endemic, then you could consider screening those patients to see if they're colonized or not. We would like to work on screening tests that are less reliant on culture and more reliant on more rapid ways to screen. So we're talking molecular methods, et cetera. That is something we're actively working on with multiple partners. So I think that we're moving toward that sort of strategy instead of sort of wait and see what happens approach. We would like to really get out on this and see if we can't contain it. But, again, it's clearly going to be challenging. It's going to take all of us, working together and being aware of it and taking the extra steps to try to identify it as early as possible and then contain it.
Yeah. Final pertains to go to and from a long-term care facility into a hospital and then back. Are you starting to create surveillance programs to identify if patients are colonized within these long-term care facilities?
Yeah, thanks. That's a wonderful question, and certainly a challenging, I think, environment for all of us. And certainly whoever asked that question probably knows that these long-term care facilities, or these LTACs, these long-term acute care facilities, are a real challenge for infection control. So yes, we are. We have identified that sort of transmission and that sort of movement already with Candida auris. We know it's happening with obviously other organisms. I think it's a certain weaker spot in our overall infection control approach, and so I think we all need to realize that that's something we have to work on shoring up our abilities to do good infection control across settings and those sort of settings, realizing that these, for example, these types of patients that we're seeing so far in the Candida auris cases, are very medically experienced, and they are moving back and forth. So it's definitely a focus of our thought and trying to come up with some general ways in which to work in that environment, but it is definitely a challenging environment.
Well, thank you so much, Dr. Chiller. I think it brings us back to the fact that we, along with the Centers for Disease Control and Prevention, are raising awareness this week related to fungal diseases. And I think this webinar certainly has highlighted the importance of being aware of these diseases, particularly C. auris, and starting to become aware of some of these decolonization and infection control policies that you will be continuing to work on. So I'd like to highlight that once again and encourage our participants to visit your website for any additional information.
Well, I appreciate it again, and I thank you all for those who listened today, and thanks for joining in this first annual Fungal Disease Awareness Week. And we are here to provide support and answer questions, and happy to field some email questions through CIDRAP if those come up. Please just submit them, and we would be happy to respond to all of them en masse if needed.
Thank you so much. We appreciate that. I just want to remind our participants that our webinar was recorded today, so it will be available later on our YouTube website, on our CIDRAP Antimicrobial Stewardship website. Dr. Chiller, thank you, and thank our participants for listening today.